Hello, my name is Neil Gertz. I'm a first-year internal medicine resident at Los Robles Regional Medical Center in Thousand Oaks, California, and I'm here to present a case of daptomycin-induced eosinophilic pneumonia. Before I begin, I'd like to send a big thank you to Dr. Nathan, Dr. Tabbitt, Dr. Merchant, and Dr. Tacker, who were all extremely instrumental and helpful during this case. A brief introduction. Daptomycin is commonly used for methicillin-resistant Staph aureus infections, but one rarely reported adverse reaction is daptomycin-induced eosinophilic pneumonia. It is currently unclear how or why the drug produces this reaction. Workup includes ruling out other infectious causes and discontinuing daptomycin. Bronchoscopy showing more than 25% eosinophils is diagnostic. Here, we report a rarely described case of daptomycin-induced eosinophilic pneumonia and discuss its management. A 59-year-old female with a past medical history of asthma and hypertension, who 10 days prior to presentation was diagnosed with shingles on the right side of her neck and subsequently treated with a 7-day course of acyclovir and prednisone. She then began to experience a painful rash with draining abscesses on the back of her neck for 1 week. On original physical exam, multiple indurative barnacles which were tendered to a patient were appreciated on the right side of her neck down to the cervical spine. She also had a right-sided facial lesion which was indurated and tender, but did not have obvious functions. Emission labs showed a WBC of 26,500 with 95% neutrophils. Infectious disease was consulted. She was started on vancomycin and ceftriaxone, and within 2 days was noted to have more functions on the right facial lesion. She subsequently underwent an incision drainage of this lesion, and closures demonstrated MRSA. Throughout her brief hospital course, patient experienced an improvement in symptoms along with resulting leukocytosis, but had side effects with vancomycin, including pruritus. She was thus discharged on IV daptomycin through 125 milligrams once per day via left upper extremity PICC line. 11 days later, patient presented with acute onset of shortness of breath along with pain at the side of the PICC line. CTA demonstrated right lower lobe pulmonary embolism, and a venous upper left ultrasound extremity demonstrated a thrombus surrounding the left brachial, axillary, basilic, and subclavian veins. She was then subsequently started on Lovenox, a new PICC line was inserted, and was discharged home on IV daptomycin and Lovenox. 4 days later, patient presented febrile at 102 degrees, along with associated chills and a productive cough. Her last dose of IV daptomycin was a day prior to presentation. A white blood cell count of 13,000 was noted, and chest X-ray demonstrated bivascular airspace opacities. Chest CT demonstrated bivascular airspace opacities with scattered subpleural nodular airspace opacities, mild bronchiectasis with peribronchial thickening in the lower lobes, small mediastinal lymph nodes with a prominent right hilar lymph node measuring 11 to 12 millimeters, which were all not present on CT of chest on previous admission 4 days prior. Daptomycin was discontinued, and the patient was started on IV vancomycin via slow infusion and azithromycin. Blood cultures were negative. CT neck was negative for Lemire syndrome. Patient underwent a bronchoscopy which revealed 28% eosinophils on bronchial alveolar lavage, which was consistent with eosinophilic pneumonia. Sputum and bronchial alveolar cultures were both negative as well. Coccidioidomycosis serology and urine antigens for Legionella and pneumococcus were all negative also. Oral steroids were not started due to the history of recent shingles infection. On discontinuation of daptomycin, patient endorsed improvement in dyspnea along with a decrease in cough, resolution of leukocytosis, as well as having adequate oxygenation or room air. Follow-up chest X-ray demonstrated mild improved aeration of the bilateral lung bases. Under imaging, one can appreciate figure 1 and 2, which CT showed new mild bivascular airspace opacities with scattered subpleural nodular airspace opacities. In summary, acute eosinophilic pneumonia is a type of pneumonia that is known to be usually idiopathic or drug-induced. Workup is to rule out infectious etiologies and obtain a history of known medication-inducing causes. Daptomycin is a lipopeptide which is commonly used for treating skin, tissue, and bacterial infections caused by MRSA. Its mechanism of action is by disrupting the cell membrane of gram-positive bacteria, which causes release of intracellular potassium leading to depolarization and subsequent cell death. Presentation consists of a fever, hypoxia, and dyspnea. Imaging demonstrates pulmonary infiltrates or opacities. Diagnosis is based on excluding infectious etiologies along with bronchoalveolar lavage for definitive diagnosis. Treatment is based on discontinuing the causative agent and supportive management. And now I pose the question. If a patient presented with a similar presentation, now knowing the case report, how would differential diagnosis change, or how would you reach the conclusion of daptomycin-induced eosinophilic pneumonia? In our case, we knew the history of the patient, which helped, but in almost anything in medicine, a good history is 80% of the workup. The initial encounter should also consist of ruling out other infectious etiologies, but once a bronchoalveolar lavage demonstrates greater than 25% eosinophils and other infection workup is negative, given a history of recent daptomycin use or other drug-inducing causes, one can come up with this diagnosis. And always remember to discontinue the offending agent as well, which we did do in this case. Again, I just wanted to send a thank you to all those who helped in this case and really enjoyed working together as a team. Thank you again.